The psychoactive effects of psychiatric medication, the elephant in the room. So this video series is going to be about psychiatric medications and the rise in gender dysphoria. It's also going to be about the role that the mental health system and the social justice movements are playing in such things as gender dysphoria. This video series is not to judge anybody based on their gender identity or sexual orientation or anything of that nature. It's simply my observation of what's going on, what my views are with the role of diet, hormones, certain medications, and certain sociological and anthropological factors that are lending to a clash of civilizations in Western civilization. And I'm also going to talk about why I think there's room for both sides. Okay? There's room for people that identify as whatever they want to identify as. There's also room for people with traditional values and traditional concepts on gender. So, the psychoactive effects of psychiatric medications have been obscured by the consumption of these medications, obscured by the presumption that these medications, disease-specific actions, exploiting the parallels with the psychoactive effects and uses of recreational drugs helps to highlight the psychoactive properties of psychiatric medications and their impact on people with psychiatric problems. This article will discuss how psychoactive substances, psychoactive effects produced by different drugs prescribed in psychiatric practice might modify various disturbing and distressing symptoms, and they also consider the cost of these psychoactive effects on the mental well-being of the user. They examine the issue of dependence and the need for support for people wishing to withdraw from psychiatric medication. They consider how the reality of psychoactive effects undermines the idea that psychiatric drugs work by targeting underlying disease processes. A characteristic and well-organized property of chemical substances used for recreational purposes, meaning like street drugs, is their ability to produce altered states of consciousness and concomitant changes in behavior by virtue of their action on the central nervous system. Drugs prescribed to treat psychiatric disorders, including drugs commonly classified as antidepressants, antipsychotics, anxiolytics, stimulants, and drugs such as lithium and anticonvulsants used to treat bipolar disorder also modify normal mental processes and behavior, but there has been a widespread tendency to conflate these actions with a presumed effect on underlying disease processes. In this paper, they're going to use the term psychoactive effects to refer to the way substances produce altered cognitive and emotional states which differ from the normal undrugged state, and we distinguish these effects from the punitive disease-specific effects of prescribed drugs. The distinction matters because, although significant, the consequences of psychoactive effects of psychiatric medications are not well recognized. Okay? Just like the various substances that are used recreational, each type of psychiatric medication induces a distinctive altered mental and physical state, whose characteristics depend largely on the nature of the drug ingested. Numerous studies with human volunteers and countless studies with animals document a range of ways that different psychiatric drugs impact normal cognition, emotion, and behavior. Although the term psychoactive refers particularly to mental alterations produced by drugs, most of these alterations appear intimately connected to physical or bodily effects, with many mental effects having concomitant physical manifestations together, producing a global drug effect. Sedation, for example, is both a mental and physical experience, and arousal, like that produced by stimulant drugs, has mental and physical aspects. It is likely that no psychoactive drug produces only mental effects. Some psychiatric medications produce pleasurable psychoactive effects, or euphoria, and have consequently become drugs that some people use recreationally, and sometimes excessively, leading to their designation as possessing abuse potential. This has been the fate of stimulants like amphetamines, introduced as the treatment for depressive neurosis in the 1940s. Apart from their use in attention deficit hyperactivity disorder, they are now most commonly associated with recreation and performance enhancement. Benzodiazepines and the related Z drugs continue to be widely prescribed in general practice and psychiatry, but have become popular black market drugs frequently used alongside opiates by those with serious addiction problems. Anecdotal evidence suggests that some other psychiatric medications, including Seroquel, amitriptyline, and amitriptyline, have a modest street value for their sedative effects. Other psychiatric drugs are more often associated with the experience of sharply unpleasant psychoactive effects. So some psychiatric drugs are often associated with a sharply unpleasant psychoactive effect, or dysphoria. This is most notably the case with the neuroleptic and antipsychotic drugs, but selective serotonin reuptake inhibitors, tricyclics, and lithium are also generally disliked by volunteers. The fact that these drugs are not associated with euphoria and therefore are not usually induce craving or become drugs of abuse does not make them any less psychoactive than recreational drugs, nor does it exclude them from inducing physical dependence. When novel drugs were introduced into psychiatry in the 1950s, in contrast to nowadays, clinicians and researchers expressed considerable interest in their characteristic mind and behavior-altering effects. They described the striking state of mental restriction provoked by the early neuroleptics, for example, which they contrasted with the more familiar type of sedation produced by barbiturates. The apparent indifference or delay in response to external stimuli, the emotional and affective neutrality, and the decrease in both initiative and preoccupation without alteration of conscious awareness or intellectual faculties constitute the psychic syndrome due to treatment. That's from Delay and Denneker, 1952. Reports of early antidepressants such as apraniz also described their immediate psychoactive effects, which appeared similar to those of stimulants. Few published accounts have described the subjective effects induced by many other drugs used as antidepressants. However, existing evidence suggests that tricyclics are strongly sedative and dysphoric. SSRIs and Venlafaxine, appear to produce a state of lethargy and indifference, coupled with an unpleasant state of agitation, tension, and hostility in some people. An in-depth qualitative study describes the essential lived characteristic of being on SSRIs as increased distance and disconnection between takers and their worlds. Lithium produces dysphoria, lethargy, and cognitive slowing and impairment in volunteers. Anticonvulsants today, part of the standard maintenance and treatment of bipolar disorders, show a panoply of psychoactive effects, ranging from strong sedation and cognitive slowing to anxiety and agitation. Although the immediate effects of common psychoactive drugs are best known, the continued use of drugs with central nervous system activity has further consequences for mental functioning. Firstly, tolerance to some immediate effects may develop, and secondly, additional mental or emotional alterations may occur, either as a direct result of continued presence of the drug in the body or the body's delayed adaptations to it. Tolerance is known to develop to at least some effects of most recreational substances, though it has been little investigated in relation to classes of drugs used in psychiatry. Animal research demonstrates that bodily adaptations develop within days of continuous use of the antipsychotic drug Haldol. For example, late-onset mental state changes are more difficult to ascribe with certainty to drug ingestion, but we know that chronic stimulant use can produce psychotic states, and long-term alcohol use is associated with depression, and some evidence suggests long-term use of benzodiazepines is associated with dementia. The possibility of adverse psychological and behavioral effects occurring after long-term use of other psychiatric medications has periodically been suggested, but has received little attention, despite the reasonable argument that persistent use of any drug that produces alterations of normal mental and physical states should be expected to have long-term consequences. Furthermore, discontinuation of most psychoactive substances after chronic use produces mental and physical changes. Withdrawal from psychiatric medications, including antidepressants and antipsychotics, is associated with distinctive withdrawal or discontinuation syndromes, which are suppressed by resumption of the drug. Within different drug classes, drugs with a short half-life typically provoke the more intense withdrawal symptoms. Users' own reactions to the pharmacological effects of long-term drug use and subsequent withdrawal add another layer of consequences. As with several other psychoactive drugs, withdrawal symptoms might be the most distinctive component of some people's psychiatric medication experience. Psychoactive effects and mental symptoms. People use illicit substances like caffeine, alcohol, and nicotine, use licit substances, meaning legal substances like caffeine, alcohol, and nicotine, to achieve a range of effects, including enhancing performance and sociability, producing relaxation, and managing stress or everyday emotional discomfort. People also sometimes use licit and illicit substances to combat more severe symptoms of anxiety and depression, to suppress painful memories of trauma, and to help manage or escape from psychologically or physically challenging situations, like living on the street or dealing with chronic stressors. Anecdotally, people are reported to have used illicit substances like opiates to self-medicate psychotic symptoms. Whether using drugs is ultimately helpful or harmful to the user depends on a variety of interacting factors, including the reasons for using, the quantity taken, the manner and duration of use, the characteristic physical and mental effects the drug produces, the situation and personality of the individual user, the habits and lifestyle associated with the drug's use, as well as social attitudes and legal penalties attached to it. The psychoactive properties of prescribed psychiatric drugs also interact with the symptoms of mental health disorders, again in ways that depend at least on the nature of the symptoms Okay, the properties of the drug and the social circumstances of the user, for example, the particular quality of physical, mental, and emotional restriction produced by neuroleptic and antipsychotic drugs was well recognized in the 1950s to dampen intense psychotic thoughts and experiences and other states of agitation and arousal without simply putting the patient to sleep. This theory of neuroleptic action is supported by more recent research that confirms that antipsychotic drug treatment more commonly reduces the intensity of salience of psychotic symptoms rather than removing them altogether. So it doesn't remove them, but it increases the severity. Such results are confirmed by patients' descriptions of how psychoactive effects of antipsychotics reduce psychotic symptoms while also suppressing other aspects of mental activity. So they're suppressing other aspects. These characteristics, effects of neuroleptics, make them usually effective, although not necessarily safe agents. So they might be effective, I doubt it, but they're not necessarily safe for a practice of rapid tranquilization and for the control of symptoms of mania. These effects may also be seen as useful in other circumstances involving impulsive and aggressive behavior, where alternative strategies are lacking or difficult to implement, including use in people with dementia or people who are considered personality disordered. Tolerance and other factors may counteract their effects. In some of their situations, however, the ability to flatten emotions may explain why neuroleptics are distinguished from placebo in trials of depression. And this, combined with their sedative properties, would also explain why many people find them helpful in anxiety. Usefulness of neuroleptics is limited by their distinctly dysphoric effects, however, as well as their serious physical complications, which would be expected to tilt the balance against their use for all but the most severely disabling conditions. Other drugs with sedative properties may be equally useful in some of these situations. Thus, acute mania is known to respond to lithium and sodium valprodepicote and to benzodiazepines. Drugs commonly called antidepressants produce various psychoactive effects. The sedative effects of tricyclics may be useful for insomnia, anxiety, or agitation, and these effects are not restricted to people with the diagnosis of depression, as reflected in the continuing popularity of low-dose tricyclic prescribing. Benzodiazepines may be preferable on safety grounds. However, if temporary sedation is what is intended, the benefits of other antidepressants are not so clear. The emotional flattening or disengagement described in relation to SSRIs may reduce feelings of depression, but the generalized nature of this effect and its association with loss of libido would argue against the utility of these drugs in depression. We can speculate on how other psychoactive drugs, such as amphetamines, which induce euphoria and were long used as antidepressants, and opiates, which produce emotional anesthesia, might reduce or mask depressive symptoms. Drugs that produce short-term mood elevation, however, typically require increasing dose to maintain this effect and entail dysphoria when they are discontinued. No known substance appears capable of producing long-term mood elevation, which hints at the misleading nature of the term antidepressants. So it's not going to cause long-term mood elevation. It is not truly an antidepressant. Use of psychiatric drugs is only worthwhile if the benefits outweigh the harms. Calculating a harm-to-benefit ratio is a complex undertaking. However, given that what is considered harmful or beneficial varies according to many factors, including the perspective of the observer and the phase of treatment,
Individuals will also have different subjective responses to prescribed drugs. Just as people respond differently to recreational substances, the lack of data about the consequences of long-term use of prescribed psychiatric medications on the full range of human emotions and cognitive functions further hampers a thorough and balanced assessment of their value or otherwise, especially since they are normally prescribed for months and often for years. Moreover, it is often the subtle and easily overlooked aspects of drug treatment that users find most troubling. Psychoactive effects and mechanisms of action. So what I want to point through with this study, by reading this study, is that the psychoactive effects of street drugs and the psychoactive effects of psychiatric drugs are not too different. Drugs with psychoactive effects, whether taken for therapeutic or recreational purposes, will affect your thoughts, feelings, and behaviors that are constitutive of conditions referred to as mental disorders. They will therefore impact the self or clinician reported measures of psychological symptoms in placebo-controlled trials. Yet because these psychoactive effects have not been controlled or accounted for in the vast majority of clinical studies of psychiatric medications, no one is in the position to state whether these drugs have, in fact, any other type of reliable action relevant to the treatment of symptoms. Studies that compare a drug thought to have a disease-specific action with a drug that produces similar psychoactive effects, but is not thought to act on the disease process, might be able to clarify how this works. So what you could do is you could take two sedatives like an opiate or a barbiturate and compare that with an antipsychotic. They're all sedating, okay? Now, do they all have a similar effect on the person? That would be a good question, wouldn't it? Two early studies found that antipsychotics were superior to a barbiturate in people with psychosis, but it had already been noted that antipsychotics produce a different sort of altered state from barbiturates. Two studies compared lithium to antipsychotics for the treatment of various psychotic states, and neither showed any difference. So lithium, which has not that many side effects really, if you're taking it in low dose, like lithium ornithate, the supplemental lithium, it's not going to cause crazy effects, but it has some of the same effects at lessening the severity of the psychosis. Although one of the studies claimed to show a differential effect on individual symptoms, this was only achieved through a complex analysis that left numbers small and most differences statistically non-significant. Amplified placebo effects may also contribute to drug placebo differences in randomized controlled trials. Apart from their direct action on symptoms, psychoactive and physical effects may reveal to researchers and participants in placebo-controlled trials who is receiving active medication and who is not, causing the placebo effect of medication to be amplified and to exceed that produced by inert placebo tablets. Placebo-controlled studies cannot, therefore, in principle, establish whether a drug works if it does. If it does by reversing an underlying pathological process. Dependence. It is now accepted that all major classes of psychiatric medication produce withdrawal symptoms. It is now accepted that all major classes of psychiatric medications produce withdrawal effects. All psychiatric medications produce withdrawal effects. These effects are significant not only because they can prevent someone from stopping medication when they do not need it or want it anymore, and that's a big thing. Do you need a medication or want a medication? Who's it up to? Is it up to you or is it up to the psychiatrist? Think about that. Okay, this creates a situation whereby patients become psychologically as well as physically dependent on their medication. So they're psychologically and physically dependent on their medication.
which actually makes them dependent on who? The prescriber. Drugs like antidepressants and antipsychotics are being prescribed for longer and longer periods, suggests that some people may find it difficult, either for physical or psychological reasons, to stop the medication. Conclusions: approaching psychiatric medications as drugs, which produce immediate and delayed psychoactive effects, and which induce tolerance and dependence, fundamentally differs from the conventional understanding that suggests these drugs exert specific actions on presumed underlying disease processes. According to the conventional view, the drugs' psychoactive properties are merely incidental side effects. Okay? So think about that. Psychoactive properties are incidental side effects. Despite 6 decades of intensive research in neuropharmacology, however, there is a lack of evidence that psychiatric drugs have a disease-specific action independent of their demonstrable psychoactive effects. These facts suggest that a radical change of thinking may be necessary about the nature, possibilities, and limitations of psychiatric drug treatment. Okay, moving on. So when we get back, we're going to start talking about what drugs cause gynecomastia in men. Okay? So gynecomastia is a condition in which men develop breasts. It's usually physically harmless, but it can lead to unwanted appearance changes. Many medications can cause gynecomastia. These include antipsychotics, and prostate cancer medications. If you have gynecomastia or are concerned about developing it, talk to your healthcare provider. They can offer management tips, including making potential adjustments to your medication routine. And I'll be covering this in depth in the next videos.